for the last session for 2020 of the Living with COVID-19 webinar series with Chatham House Distinguished Fellow and Epidemics Authority, David Heymann. Today, we're going to be talking about COVID-19 tests, what they can do for us, what they can't, who should get one, when does it not make sense, how reliable the test results are, what kind of decisions should or should not be made on the back of test results, etc. With us today to discuss these issues are two leading lights in the COVID-19 diagnostic test space. Rosanna Peeling is Professor and Chair of Diagnostics Research and Director of the International Diagnostic Centre at the London School of Hygiene and Tropical Medicine. Sergio Carmona is Chief Access Officer at FIND, which is a global non-profit organization that drives innovation in the development and delivery of diagnostics for major diseases affecting the world's poorest populations. And FIND is very much involved in developing and delivering all these COVID tests, and especially to developing countries. So welcome to Rosanna and Sergio, and thank you so much for joining us today. Before we dive in, I'll just remind everyone that the session is on the record and questions can be submitted using the Q&A function on Zoom. Upvoted questions, as usual, are more likely to be selected. So if you have a question that's similar to one already in the Q&A, please upvote it, because I'll be looking at the upvoted questions first. David, I want to start with you today, this time. As we can all remember, there was a mad scramble at the beginning of the pandemic to get hold of tests. It was almost a supply chain wars. There are now hundreds of rapid diagnostic tests emerging. I guess my first question, David, would be, with the advent of vaccines, do we really need so much testing anymore? I mean, do they have a major role at this point or for much longer in the pandemic? So what do you see as their role at this stage of the pandemic?
Well, thanks, Emma, and thanks to Sergio and to Rosanna for having joined us today. Regarding diagnostic tests, there will always be a need for diagnostic tests. A vaccine is one tool in the war chest against this infection, and there will be many, many more tools coming along, but diagnostics are at the base of that. And as you'll hear from both Rosanna and Sergio, there are various types of diagnostics. There are diagnostics which can identify the virus that's present in people, and that's useful, for example, in diagnosing people who have signs and symptoms of COVID to see whether or not they actually have the infection, and if so, then they're isolated and managed in a health facility. At the same time, surveillance systems, which are there detecting respiratory infection, also have to be linked with diagnostic testing to see whether or not the virus is present and whether those people need to be isolated and managed. It's also important for other new ways forward in the pandemic. And I know that the airlines are working quite closely together to try to see what testing strategies might be useful to see if virus is present in passengers before they travel and when they arrive in the destination country, and also maybe 3 to 5 days after they've gotten off the plane. So diagnostic tests for virus will continue to be very important moving forward, as will tests for antibody. And as you know, antibody is the marker that tells you've been infected with the virus. It's the antibodies that are developed to the virus. They're important because with that, you can tell where disease has occurred in the past. But it's also important because it may be that as we begin to vaccinate people, we'll need to know after vaccination whether or not the vaccination has taken. And therefore, antibody will be an indication that the vaccine has taken. However, there's one caveat with that. We don't understand yet whether those antibodies are what's protecting people against serious illness or against infection. But they will have a role to play, I'm sure, and I'm sure Sergio and Rosanna would agree with me, in the vaccination strategies that are being developed. And in addition, we don't yet understand whether vaccines only prevent serious illness in people who are vaccinated, or whether they actually prevent infection. And so virus detection tests will be important moving forward in making sure we understand how vaccines work the best as well. So the answer to your question, long-winded as it was yes, diagnostics will play an ever increasing role in the fight against COVID-19.
And I guess that's tied up with the whole idea of vaccination proof certificates, that especially if it doesn't prevent you from becoming infected, but it may prevent you from becoming ill if you get vaccinated, there would be a need for a test. You may be infected after vaccination. So do you see it kind of coming together, the two coming together? Or because a lot of people think, well, if you just got proof you've been vaccinated, then you don't need to test. But that would
Yes,
only be if the vaccination prevents infection. Is that right?
there's lots to learn. Yeah, what the perfect vaccine is one that prevents infection and prevents carriage of the virus in the nasal passages. And if you have a vaccine like that and it's long lasting, then a vaccination certificate might be useful at some point. But right now we don't understand enough to say whether or not vaccine certificates are useful. But I know that the airlines are also considering this in their work together to try to make travel even safer than it is today.
Okay, thank you for that introduction. So I think we can all accept that we still need them, still need tests, and very much. So Sergio, welcome. Can I turn to you now to walk us through where we are with diagnostic tests in terms of what choices do we have today? I mean, how many are there to choose from? What types of tests are available? And which should be used when, the pros and cons, and what do they tell us and what do they not tell us? And have you got any notes of caution as to how they should be used?
Great. So there are a lot of questions there, and to elaborate from where David started, the two big categories: tests that tell you you had the infection, those that are based on antibodies, and tests that tell you you currently have the virus. And there may be in that group, there are two types. One that looks at the genetic material of the SARS-CoV-2 virus that causes COVID, and the one that tells you you have a protein or a structural element of the virus, right? So there's a genetic material one and one that detects a protein of the virus. Both of these tests can be deployed in various settings. Some require a very sophisticated instruments that allow for that genetic material to be amplified, so-called PCR or nucleic acid amplification types of tools. And then there's others that pick up the protein, and those are the new ones that everyone's talking about, these point of care tests that are easier to use, that can give you a result in 15 minutes and do not require instruments as such. The PCR is very accurate, but the time for a result to become available is still challenging in many settings. So here's the benefit between highly accurate, very specific tests, but takes you many days to get a result versus a test that may be slightly less sensitive if you want, but can provide a result immediately. And maybe going to David's points earlier, I would approach your question in two ways. Do we want to use the test to treat a patient that comes with symptoms and manage it, confirm and see what the outcomes and risks are, versus, as you pointed out, this testing that happens with people that may be asymptomatic or symptomatic in settings outside of their traditional health services. So they have a role to play in many of these. Now, how many are there? Well, this year we've seen an amazing pipeline that has developed by manufacturers and biotech companies. So initially they were just a handful. Now we have over 100 or more of these tests, and we at FIND have evaluated several of these too. Depending on the regions you are, the FDA emergency use authorization has a list. WHO has a list called the emergency use listing, and currently there are at least 2 or 3 listed there that can be safely used, and many others are in the pipeline being assessed for both accuracy, ease of use, etc. But a point that I want to really hone in is the value of rapid tests in terms of the time of a result, right? So you can then isolate an individual that could potentially infect others in 15 to 30 minutes. And that has a major implication at public health level for containing this pandemic.
Oh, okay. Thank you, Sergio. I just wondered, are they all equally good? You said hundreds to choose from. I'm wondering how does, especially when people are buying the tests themselves. I mean, are they all equally good? Is there some standard agency that gives like a seal of approval that, you know, this one
Sure.
is good and works well,
Yeah.
or do we not know?
So WHO has issued already what they call their target product profile with thresholds of what is the minimum acceptable as to and versus some a desirable threshold, right? So we use that bar, if you want, both for sensitivity and specificity. And these are difficult maybe terms to use, but how good are they in detecting someone that is truly positive versus someone that it isn't, and how down in little particles can they get to? Those thresholds have already been established by WHO, and there are other organizations like the FDA that also have them. And we
But
use
is
that
it
to make.
marked on a test? I mean, can anybody, recipes, you know, that were uploaded on the WHO website of protocols for how to make a test, can anybody decide to make a test and sell it? Is anybody policing the quality of these tests, or is it buyer beware from these hundreds of
So
tests we've all got to choose from?
so Rosanna has got many years of experience
Oh,
in
okay.
what are
I'll
the
ask you about
regulatory authorities. Uh,
that. Okay.
I'm not, Rosanna, you know very well that field of the regulatory affairs in many regions. Do you want to take that?
Unmute yourself.
Thank you, Sergio. We've never had this situation where we are faced with having over 800 some tests being commercialized. And so every government is facing the difficulty of trying to sort out which are the good tests and which are the bad tests. I think the leading authorities for that is the US FDA and WHO. But even then, you know, for the files that are submitted to them for approval, it's only for emergency use only, which means that they don't go through the kind of scrutiny that normally a test would go through in getting regulatory approval. And so it's really paper review on the what's reported to these authorities about the sample size, about what the gold standard is used for comparison of the new test against a standard. We don't have an international standard as yet for these tests, so it's really a little bit difficult right now for a lot of countries. But if you go to the FIND website, you could filter out the tests that have been approved by various governments, and normally the stringent authorities are thought to be the regulatory authorities are thought to be the FDA, the Australian TGA, the Health Canada, Japan, and the EU. And so those are places where you could see which tests have been approved.
Okay, so is it really a buyer beware situation where there can be unapproved tests for sale? Are these 800 odd commercialized? Are they all approved tests that have been commercialized, or you're just tracking, you're aware of 800 tests out there that may or may not be approved by somebody? Or are they not allowed to, is nobody allowed to sell an unapproved test?
Well, in many countries where the regulatory authorities are not very stringent, then a lot of tests are being sold and used without any evidence that they work. And so at least we know that the ones that are, have been submitted, the companies that have submitted their tests to FIND, there's a level of scrutiny, right, Sergio? They have to have at least a CE mark. So that we know that they comply with the International Standard Organization Code of Conduct for Manufacturing Quality. But quite often companies would submit files on their accuracy based on, you know, this, whatever panel they of evaluation panel they could get their whole their hands on. And in this pandemic, trying to figure out what are the specimens that could be used, it's subject to a lot of variation. And so, for example, if I want to make sure my antigen tests look good, I would use lots of samples with very high viral load. And so then the tests look like, it's 100% sensitive. But in fact, in the normal population, you need to know, how, what is the limit of detection, right?
So yeah, that accuracy actually was going to be my next question to you, Rosanna. And what I was hoping you could come in on is how much confidence can we have in any of these test results, especially if we get a negative result. I'm thinking about, of course, some governments will provide tests or offer tests, but some people may want to get tested off their own volition. But how sure can we be? How reliable are they? And what determines how reliable any result would be?
Yeah. So I think in general, for any test, we talk about the sensitivity and the specificity of the test. And the sensitivity is really both these values are actually inherent characteristics of the test. They don't change at all. That is a property of the test, right? But when you apply that test to a population, then, depending on the prevalence of disease in the population, then its predictive value changes based on the relationship between the sensitivity and specificity and the prevalence of infection. So for example, if you use a test for a molecular test to try to confirm a COVID case in a patient presenting to hospital or presenting to a testing center with symptoms consistent of COVID in this pandemic, then the likelihood of that patient testing positive is anywhere from 30 to 50%, 60%. And so then the test has very, very high predictive values for telling you that it's a true positive. But if you then use the same test in a population, in the general population, and try to look for positives, then you may get actually more false positives than real positives. So, the prevalence of infection in the population really has a lot to do with how how accurate your test results may be at the end. So what we're saying is that, if you are using a test, beware how you use a test in the context of your testing strategy. Which population are you testing? What's the likelihood this population would become positive? So let's take, so first we have the symptomatic patients who are highly likely to become positive. Therefore, these tests, and WHO has set a minimum performance threshold for the antigen, the rapid antigen test, as having a sensitivity of 80% and a specificity of 97%.
Sorry, what's that? That it picks up 87% of cases.
Yes, and will miss about 20% of them. And the specificity is, it would assure you that when you have a negative test, it's only missing 3% of those tests. And so, I think that
does that mean that the tests are out there comply with that, or not necessarily? That's the standard. That's the reality when you're buying a test.
No, not necessarily. Yeah. So quite often, I mean, I shouldn't say this as general statement that what's on the product insert as to the sensitivity and specificity may not be, very accurate, depending on whether the company knows how to do these clinical evaluations. I've had in the past, when I was at WHO, a company come to me with a rapid syphilis test and said, our test is 100% sensitive and 100% specific. And so I said, great, that's the test we need to screen pregnant women. And I said, how many patients did you have in your study? And he was very, he said, 100. And I said, how many are syphilis positive? And he said 3. So, so that's, to get 3 out of 3 positive, that's not telling us a lot because we are not very confident that, it would have,
Okay, so this all goes to, and maybe I'll go to David on this, of the public use of tests, because, with the arrival of these rapid tests and being able to buy them, we'd expect that a lot of people will be using them and determining their behavior, their risk behavior, based on the results they're going to get from these tests. So do you think that, say you buy a test and it says you're negative, coming up to the holidays now, it's festive season and we want to mix the generations, but we want to protect our loved ones. If I buy one of these tests and it says I'm negative, can I just relax and think, okay, I'm not infected, I'm not at risk to my grandparents, I can kiss hug them, everything will be fine. Is that what these tests, is that how we should be using them? Is it safe to conduct ourselves that way and bring these tests into our lives in that way? You're on mute, David.
Yeah, Emma, it's all about personal risk assessment. And personal risk includes many different factors in addition to testing. So if you've been at a Christmas party 4 days before you plan to go visit your grandparents, no matter what your test says, you should not go, because you might have become infected at that party and you could then infect your grandparents or your parents. It's all a matter of where you've been that's really the most important. So if you've been staying at home for 2 weeks and you haven't been exposed to any parties or any gatherings of people, and you want to do a test to make sure that you're not infected, then maybe you'd want that just for your self-assurance. But a test alone is no guarantee of being free of infection, because you could be testing yourself. You could be testing yourself, Emma, at the time before your test becomes positive even. It takes a while for tests to become positive.
Meaning
so all
you
of the
negative, but you are infected. Does it mean it's missed an infection, or does it mean that your infection hasn't progressed enough? To me, that's a failure in the test. It's got a false negative. Or is it not that simple?
It's not a failure in the test. It's a fact that people don't develop a high enough level of the virus to be detected by this test by the time they've been tested. So if you were exposed 2 days ago and had an antigen test, a rapid test today, the likelihood is that it would not be positive even if you're infected.
Okay, so does that mean you should test yourself again or not bother?
Yes, that's one solution, is to test yourself again. But the most important is to take all the factors about yourself together as you do the risk analysis, not just a test. A test is for certain purposes, but it's also dangerous to rely only on a test.
But if you're going to isolate for 2 weeks and you're not going to see anyone, you don't really need a test, do you? Because you wouldn't have been exposed.
Well, if you're going to isolate and you want to get out of isolation sooner, you might try to think when your contact was, and then based on 7 days after that, you might want to test yourself again. And if you're negative, then you might want to argue that you could get out of self-isolation.
Okay, so I don't know, fair enough, David, I don't know which one of you can answer this question, but this is something, say you test positive for PCR, that means you've got the virus in you. Does it mean you're infectious, that you can give it to somebody else? Could you have the virus but be past the point where you could spread it? Or, what do we make of this, and what is a PCR actually telling you?
Okay, so that's become very, very interesting question. And we've known this also from other viruses, but now the evidence is coming along quite well, that a PCR positive test is like a sliding scale, right? It's how positive are you? I don't want to get into too much of the technicalities, but PCR is so sensitive. It's able to pick up such low levels of the virus. I don't want to call it viral dust, but they're kind of, that it depends entirely where you are in the curve, how to interpret that result. And many settings interpret it differently. Some are quite categorical. irrespective of how strong that PCR signal or NAT testing or whatever it is, you will be called positive, right? The difference here between an antigen RDT and PCR and that relationship between transmission is something that has now, there are a couple of new meta-analyses or systematic reviews that are starting to show that not all PCR results, the very, very sensitive a result that picks up very little of the virus, it's unlikely to transmit to others. But there's also, as David points out, there's also a viral cycle. In medicine, we never used to treat a pathology report, a result, right? We treat the patient or the individual, right? And you will need to know what was the history of exposure, when did the symptoms develop to interpret that result. So we know that between day 0 of symptoms onset to 3 to 5, that's when you're most likely to be shedding a lot of virus, and your PCR will be definitely positive. And so will be your antigen RDT or this rapid test. But later, that curve then starts flattening, and maybe 10 or 14 days after symptoms onset, your PCR may still be positive, but your antigen RDT may not. And that's when you start distinguishing. Another result is wrong. It's just that one is picking up leftovers of the genetic material of the virus, and the other one is picking probably more likely viral particles that could transmit to others. So it's a time issue as well. And maybe, and we'll see how this looks, that the antigen RDT will correlate more likely with that contagious or ability of the virus to infect others.
So it sounds really complicated, actually, and I'm thinking about how we might use test results kind of strategically. And Rosanna, I want to come on to strategic use of tests, since that's the real theme of what we're discussing today. But I'm thinking how governments or businesses or whoever is judging might use a PCR positive test in order to exclude someone, and or even to politicize it. Like, you know, so much in this pandemic has been politicized, and infection status, you can imagine, could become one of those types of issues. That if it takes such skill and professional expertise to be able to interpret and piece that together, it's not just yes, no on a test result. Do you see any danger in the way this is going forward, and how this might be used or misused? Or do you think, as a group, because we've got the vaccine, that's going to become a non-issue, we don't have to worry about that? Is there a danger here in the way tests are being used?
Yes, and just as Sergio has said, you know, different tests can tell us different things, but ultimately we have to interpret a diagnostic test in the context of the patient. The history, whether they have symptoms or not, what's the exposure, what were exposure events that they've been exposed to recently, etc. And so I think there's really a danger if we don't have more science literacy amongst policymakers and public health experts, and they together need to agree on how to use these tests so that the results are interpreted the right way. And if politicians and public health experts, as we have seen in some countries, don't agree and don't use science as a basis for going forward, then the public is even more confused about it. And when the politicians and the public health experts don't agree, then the public has very little confidence in what the, any restrictions, isolation, or any sort of lockdown measures that countries decided to use. And then we don't have compliance with those. And so the epidemic would rage on in that case, regardless of how you test, how many people you test. And personally, a lot of people have asked me, how do you interpret my results? And really, I have to ask a whole lot of questions before I could say, yes or no. I think with regard to shedding, as Sergio says, the data is now coming forward. There's been some small studies looking at using culture to see how long the virus becomes, it stays infectious. And according to these small culture studies on culture from people with viruses, is that they usually are not shedding infectious virus after day 8 from the onset of symptoms. But that's only a general average. I think it varies a lot with people, with what viral load they have, etc. And so there's no simple answer, unfortunately.
God forbid. Okay, David, I wanted to ask you, so actually you could all speak to this, but I wanted to ask David first on this. Mass testing. So several countries, and with the arrival of these rapid diagnostic tests that Sergio had alluded to, and Rosanna, that they're less accurate. I'd like to find out how much less accurate, how dodgy are they in terms of accuracy. But what do you think is there a wisdom to pursuing mass testing? Is it a good idea? Will it totally transform our lives and how we get through the rest of this pandemic once we have mass distribution of these tests? Is it safe to use mass testing with these rapid tests to return to normal life, David?
Well, Emma, I think it depends on what the goal of that testing really is. Every testing strategy has to have a goal. And it's never been clear to me what a testing strategy is if you want to test your entire population. What do you do with the people who are positive? Do you force them to isolate? Do you ask them to isolate? Do you exclude them from society? It just needs to be thought through very clearly before you start testing. Early in the pandemic, countries were saying, oh, we've done 1 million tests today. We're in very good shape. Well, that means nothing really to me or to an epidemiologist. What it means is I did 1 million tests because I wanted to see how many people in that 1 million people, in that 1 million population were infected so that I could do something with them, so that I could isolate them, so that I could provide them guidance. So I think it comes back to why are you testing, which is important. If you're testing an entire population in order that you can identify those who are infected and remove them from circulation, that would be something which would have to be studied by an ethical group before it's done, and by a whole series of other people involved in daily life, in the medical care of people, in health facility accommodation, a whole series of things in order to determine whether or not that is a useful strategy. But that's my view. And I know Sergio and Rosanna will have other views. So I would go to maybe Rosanna next to ask her what her view is.
Yeah, and Rosanna, can you talk a little bit about strategic use of testing and what that means and what the concept is? And are countries, are they being strategic about it, or is it chaos? What's going on?
I think we, I don't think any country has come up with a very clear mass testing strategy yet. As David says, there are many questions as to what type of mass testing do you do? Do you do antibody testing to find out what the true extent of the pandemic has been? Or do you do virus testing or antigen testing to know how much viral load is still in the community, right? And what's the force of transmission? And so depending on these purposes, you need to think about also what tests to use, how to deploy them, what are the logistics of getting supplies to everywhere around the country. And that's not a small thing. Logistics, and you have to do them in a limited time span, otherwise it's no good, right? You need to do it as a snapshot. And if you can't do it in a very short time span, you elongate it to months and months, then the picture evolves so quickly, then you're not getting a snapshot. And then, there's a cost, right? We're trying to open up the economy so that people can get their jobs back and get their lives back. is that a good use of money to do the testing, or should you spend them on vaccines? Should you spend them on compensating people who are unable to make ends meet, etc.? So there are so many questions about what a reasonable testing strategy should be. Sorry.
I don't know, is that your alarm? Alarm clock.
Sergio, I'm going to move on to audience questions in a minute.
Yeah.
But Sergio, if you want to come in on anything urgent on that, but other than that, if you think enough's been said, I wanted to just squeeze in there the whole issue of quality control and the prospect of fake tests. Is there a concern with that? Is it going on? Thinking back to the consumer, of how does a consumer make sense of all the 800 or whatever these tests, and do we know it's a real test, and and if we're doing it ourselves, is that okay?
Okay.
What are your thoughts on that? And then I'll go on to the questions.
The question. So maybe we should qualify what we're talking about. So this mass testing that is happening in the UK and also in many other colleges, for example, in the US, those tend to be of two types, those PCR or genetic tests, and those are generally operated by pretty well-trained, sophisticated professionals. So the error likelihood of getting the sample incorrect or getting it's a much more controlled environment. What I remember seeing a little bit about the UK is there's two things. One, the self-collection, right? That you kind of get a brush, put it on your nose and send it in the post, or someone picks it up for you, versus a professional collecting the specimen and sample and then doing a PCR. There's a lot of variability in there that is not intricately a fault of the test that you may or not be using, right? And then now we know that the FDA has already approved one self-testing, which does the full end-to-end, right? You self-collect and you self-run it, and you a bit like a pregnancy test. And with that, obviously, if you don't collect the specimen correctly, even a well-performing test that is FDA has all the bells and whistles from quality assurance point of view can still fail, right? So we need to distinguish those errors that come from badly used rapid tests versus those that are still within the professional, in the hands of professionals that could still give you errors. In terms of fake and poor quality, this is what we used to call post-market surveillance. I think maybe WHO has a different name, both for medicines and diagnostics. There are systems, maybe more robust in some countries than others, that constantly check fake tablets, fake diagnostics. I must say, with COVID, there's been such a surge and such a massive effort in getting these tools out there that I think the amount of post-market surveillance that needs to take place probably could be strengthened. We saw the bad press at the beginning of the pandemic on countries buying millions of antibody tests and then having to retract them. I think many countries have learned from that, and hopefully good measures are being put in place to address that. How can the consumer protect themselves? I think through their own health regulatory authorities and see what's available.
Okay, thank you. I want to move on to audience questions now. The most upvoted question is from Louise Hart, and she's asking, currently the rapid diagnostic tests are nowhere near as reliable as PCR swab tests. Do you anticipate the rapid tests improving in reliability in the same way that PCR tests have done in the past 8 months? And I could, I guess, Rosanna or Sergio, we still haven't got to the bottom of these rapid diagnostic tests. How inaccurate are they? I mean, are they missing 1/3, are they giving a lot of false reassurance that you're clean when you're not? What is the accuracy? And then if you could please tack that on to answering Louisa's question, who's best placed to take that?
Sergio, you want to try or?
Okay, let me give it a shot. I'm getting some
And
tricky
then
questions here.
Please
So,
ask the accuracy so that we can see the difference between a PCR, the certainty in the result, versus these others. And I know with 800 or whatever, there's a lot of variation, but vaguely type of test.
Yeah. So maybe I'll keep it simple, right? So as Rosanna put it, there's 80% sensitivity and then 97. I'm trying to give you those numbers. So that means out of 100 people, right, maybe we'll miss 20%. But that improves a lot when you're just using the test with those individuals that come, we tell you, I developed symptoms yesterday, I'm not feeling well, I've got this sore throat, the fever, the ache. In those individuals, we know that their performance is much, much better, right? In the 90s, right? If you're going to use this test, let's say for truck drivers that are crossing one border to another, and the prevalence, so these are healthy individuals, they're fit, they're able to drive, they come from countries that are unlikely to have big numbers of people infected, that's when you may see a drop of, into the worrying below 80s, if you want. But in that context, leaving 80 trucks full of very essential commodities crossing one country to the other to open economies and leaving 20 truck drivers behind that can maybe either repeat or get a PCR and confirm that if they're truly negative or positive, is not such a bad thing, right? Now, that's it. So sorry to qualify the question in terms of context. For people that are sick with symptoms, the likelihood of getting these results incorrect is much lower.
Okay.
Now,
Yeah, and Emma, I'd like to say, it's we shouldn't think of molecular and antigen tests as either or, because I think even in settings where you do have molecular tests, there are times when a rapid result, even though it's less accurate, would actually give you the kind of action, that public health action that you need to improve our response to the pandemic. For example, in a very busy hospital, when the outpatients department is inundated with people with COVID-like symptoms, and you need to triage them, even if you have a lab on site, these patients, according to studies that's been done, could be waiting as much as 20 hours for their molecular test result, because it just takes time. These good tests take time. And so then you have a situation where it's overcrowded. You may be exposing people who are not infected to those who are infected, or they're being moved around. There's some studies to show that these patients in the 20 hours get moved around to different spots in the hospital, and therefore actually spreading the infection around the hospital. The same with care homes for the elderly. When they are so vulnerable, having a rapid result would be really useful for rapid isolation, and care for those patients. And it's really, the 80% is not a random 80% that you pick up. It's not like luck of the draw. It's actually picking out the people with very high viral loads compared to the 20% that test negative. Those people have much lower viral loads and therefore may be unlikely to transmit. So having a rapid triage system in some cases, even when molecular testing is available, is something to consider, and not to say either or, right? And then the other thing that I want to say is the quality of the testing is important. So we talked about the quality of the test, but if the testing is not done correctly, we're still not getting good results. So that's really
both together, both tests together on the same person at the same time. Is there any value in that, or have you got to pick between the two?
So I think that's an issue of resources, right? Yeah. So in some countries, I think Singapore has done really well. They have an infrastructure that can use both concurrently. All the positive get quickly confirmed. And then because of those false positive, probably only 10 or 12% are really positives, right? And then you reduce that number. And again, it's an issue. the time to act is more important, I would say, in those cases. So that and the frequency, right? If you're using these once a week or twice a week in some key populations, you probably, the idea overall, as David points out, what is the point of testing? The point, I think, of testing generally is to get over this pandemic, take out of the communities those that are positive and likely to transmit to others. The sooner we do that in a close community, let's say, the sooner it's over. And modeling has shown that timing trumps inaccuracy, if you want. So a close community that you model is more likely to overcome the pandemic if you're taking out sooner rather than later those that are infected and infectious.
But to Louise's question, do you envision that these rapid diagnostic tests might get more accurate? Do you think it's going in that direction, or are we stuck with what it's got?
Yeah, so again, someone reminded me about HIV, and David and Rosanna are veterans to many other pandemics and epidemics. But coming from South Africa, we saw how first, second, and third generations of these tests got better and better, how they became easier to use. And even today, HIV is something we already have self-testing in HIV. So we are monitoring that, and we're already seeing some improvement. It's amazing, Emma, what was done in just a few months. These kind of developments used to take years in other diseases. So yeah, my view or impression is I would say yes, but Rosanna and David have
okay. Let's accept that and move on to the next question so we can get through a few more. Here's the next most upvoted question from Dr. Anna Purna Sharma. Ethically, what do you think is the difference between, say, a yellow fever vaccination certificate and a COVID-19 vaccination certificate? David, do you want to take that first?
Yeah, well, yellow fever vaccination is known for many, many years, since the 1930s. And it's known that this vaccination prevents, it's a sterilizing vaccine. It prevents against infection. We don't know yet what the COVID vaccines are doing. Are they preventing against infection, or are they all only modifying infection once it occurs and making it so that a disease doesn't happen? So we don't know enough about these vaccines yet to say that a vaccination certificate would be useful, but it certainly is useful in yellow fever, provided it's not been faked, provided it's not a counterfeit certificate, which happens, and provided the vaccine that was used has been kept cold until the time it was used. So, you know, it's very important to understand that vaccination certificates will one day likely play a role once we understand more about these vaccines. And just like for diagnostic tests, there are an incredible number of vaccines that are under development. This has never before happened. It's usually one vaccine at a time, and it takes a long time to get that one vaccine out. So, you know, it's not possible to give all the answers. But Emma, I'd just like to jump back to this question that you asked earlier, because I see there's still confusion. And this is the question about a rapid test to look for the virus. If I want to go to Christmas dinner with my grandparents, you know, if I have a positive test, I will certainly not go. That's clear. It could be that I do have an infection and I wouldn't go. But if I have a negative test and I've been self-isolating myself for the last 2 weeks, I would still feel confident in going. But if I were to my office Christmas party last week and then tested myself and it was negative, I would not be confident enough in going, because it may be that there hasn't been enough time between the time I got infected and the test to make that virus visible. So testing is all about the odds and about a whole series of things in risk assessment. And just one other thing, countries in Asia are now looking at a testing strategy before flying to see whether or not they want people to fly. And their modeling shows them that they would be that if they were doing rapid testing for the virus on each person getting on an airplane, they might have 60% decrease in people who got off that plane and went on to get infected. So they're willing to accept a risk of 40% in order that they can, in fact, begin travel onwards, as Rosanna says, to get their economy back.
So do you all think that rapid diagnostic tests at airports or connected with airline travel is going to bring us all back to aeroplanes more quickly and get us back to normal in the airline industry, aside from the issue that we can all do Zoom meetings, we don't need to travel. But as far as confidence in the experience of flying, is testing going to be an important part of that? And the way it's being envisioned to be used, as David just described, is that okay, good idea, misguided? What do you think?
I think that in terms of using these rapid tests to rule out that a person, to say that a person is negative, I think that with the current tests that we have, we can be fairly certain, the negative predictive value of these tests are good. And so we could be quite confident that they rule out a person that's infected. And so, but as David says, it all depends on the circumstance, the context within which the test results have to be read. And so I think that, some airlines are demanding that you show that you have a negative test on boarding. And some countries require that you have a negative test on entry into the country. And then 7 days after, you're supposed to report for another test. And so these strategies are being developed at the moment. And there are different models that show that they could be effective in allowing more people to return to work, to open up, different sports events, mass gatherings, etc. But we are taking some risk, and there's never going to be, no test is perfect. So, I think we use them as weapons as best as we can for the pandemic response. And, we need to balance its accuracy with its accessibility and timeliness and costs. The 3 A's that I always teach about diagnostics: accuracy, accessibility, and affordability. And accessibility includes timeliness and being able to use them well and use them and know that they're quality assured. I think those are the sort of big caveats to how different sectors use the test. But I think that it should not be used to as a condition of employment in terms of violation of rights and all that. So
sure. There's one from Toby Bonvoisin, and I think this might be for Sergio. Why were PCR tests widely available so much earlier in the pandemic than antigen tests? How can the development of antigen tests be sped up for the next emerging pathogen?
Very good question. So again, and this comes from having it's a bit like these new vaccines, right? So it's easier to generate a vaccine like the ones that we making into the press because it's new technology, right? This is genetic engineer, little piece of RNA that then can produce a protein that mimics the virus, right? The same applies. So it's much faster once the so-called Berlin protocol was released, the sequence of the genome. It's only been this year, by the way. I mean, it's David, remind me, it was January or so that the sequence was known. A couple of weeks later, protocols were developed that managed to determine how to amplify the genetic signal. And that's kind of the fastest way diagnostics can be developed, right? There's a bit of, then there was a whole market collapse. The global north had ability to buy, and every other member state was scrambling for these tests. But we know that those tests need to be run by professionals. It's prone to contamination and requires devices. Now, these new rapid ones that are simpler to use need an antibody to be developed in a factory, in a brewery, if you want, right? And to develop those and to find a clone that is good enough to pick up the virus takes time. You can't buy that time like you could with PCR. Now, having done that, WHO and many other organizations work closely with Africa CDC there was urgent need to deploy that PCR, those kind of technologies for genetic testing. Now, once these rapid tests that were produced at scale, right, because that's another thing, at massive numbers, that they were of good quality and good accuracy, as you pointed out, quickly we managed to set up studies in Europe and Latin America to check, are they really this good? And as Rosanna said, confirm that the manufacturer claims are indeed true in different settings. Once we knew that, that data was made available quickly to WHO, and within weeks, these tests became available to many countries. So I know it seems like a long time, but in normal days, this would have taken years, and it's just taking a few weeks to months. So of course, now our big effort is to ensure that these tests become available at scale, that they're also affordable to many countries that are starting to see these second and third waves. So yeah, good question.
Okay. Yeah, well, that was a good question, actually. We've got time for one, maybe two more. I'm going to pick, actually, this one. It's from Jill Murray. Assessing the reliability of diagnostic tests is clearly very complex. Could you comment on whether approved for emergency use only strategy was, in retrospect, a good one? What lessons for the next pandemic? David, do you want to come in on that one?
Well, yes, I think that, you know, Rosanna and Sergio and I have all been talking about the need to be better prepared to validate new tests when they come onto the market, because the global community is not able to do that rapidly. They have to take the information that's provided by the testing done by companies, which is reliable in most instances, but which doesn't give the variety of different types of testing or types of situation that would be important to use these tests in. And so those conditions need to be created by collecting what's called panels of sera from many different people at many different stages of infection in order to be able to better validate these tests. And so I think that as the global community becomes better prepared, one of those will be, and Rosanna and Sergio will correct me if I'm wrong, but will be to have better availability of standardized panels that can be used or collected early on in an outbreak to be used to validate tests much more rapidly than has been done now. That's called external.
So it wouldn't have to be an emergency use, it's done a full round. Is that the question? Was whether emergency use authorization has been a good idea?
They would still be emergency use authorization, but they would be validated better than they are now. But Rosanna and Sergio will have a better possible.
It's going to have to be the last question then.
I think it's again about a risk, right? I think WHO and FDA did very well by encouraging the development of these tools quickly. We will be very sorry today if we didn't have WHO emergency use listing. I would say it's not by all means perfect, but with time those things can definitely be. It's a risk strategy that has allowed for manufacturing, developing, and use of these tests at scale. So definitely.
Okay.
I don't know, Rosanna, maybe are you in agreement?
And I think that
we're at time, so I have to wrap up. But if it's quick, Rosanna, you can squeeze it in.
Yeah, I think to be better prepared for the next pandemic or epidemic, I think we need a lot more international collaboration to come up with those standardized panels for evaluation very quickly, and so that we could systematically go through the different tests that appear on the market and make sure they're good. Okay.
Okay, thank you. That was quick. Thanks for that. So there are a few more questions that all look really interesting, so I'm sorry we couldn't get to them, but that is all we have time. Some really important considerations have been raised today. So Sergio and Rosanna, thank you so much for spending your time with us today and for your great insight into this really complex world of COVID testing. And thank you all to everybody else for tuning into this last session for the year. David and I do plan to be picking up again in the new year with some new angles on this still very much ongoing pandemic. So please do look out for any announcement of when we might be starting up again. But thank you, both Rosanna and Sergio. It was
Pleasure.
great to talk to
Thank
you, David.
Thank you.
Thanks as well.
Have a great rest of the day, everyone. Thanks.
Goodbye. Thanks for
Bye.
inviting us.